This is Don Resnick, and it's my honor to introduce our refresher course, Course 404, Articular Disc, Menisci, and Labra, Structure, Function, and Dysfunction. And you can appreciate the fact that I have, beyond myself, been able to corral two other speakers, both terrific, Christine Chung and David Rubin. We decided to include articular disc, menisci, and labra in a single refresher course simply because they have many features in common. They represent transitional tissue with chondrofibrous features. They're poorly vascularized, mainly with peripheral vascularity. Age-related degeneration and calcification is seen, and in addition, trauma-related abnormalities may occur that can lead to clinically significant findings. The general objectives of our course to review the structure and function of the meniscus of the knee, the triangular fibrocartilage complex of the wrist, and the labrum of the hip and gluteal joint, and delineate the patterns of failure of these same structures. It's my honor to start off this course, be able to talk for a few minutes on the meniscus of the knee. To give you an idea of the anatomy of the meniscus, we look down on the top of the tibia from the point of view of the femur with the medial meniscus on the left, the lateral meniscus on the right, and clearly they are not of similar shape. The medial meniscus is a more elongated structure, the lateral meniscus a more circular structure. The lateral meniscus covers more of the lateral tibial plateau than does the medial meniscus of the medial tibial plateau. There are other structures in this particular drawing, but I want to call your attention to the numbers 1, 2, 3, and 4 in this picture. These are the root ligaments. We've learned a lot about them over the last decade. These are ligaments that hold the menisci in place in combination with other supporting structures. You'll note there are two on the medial side, the anterior and posterior root ligaments, numbers 1 and 2. Similarly, two on the lateral side, located closer together, anterior and posterior ligaments, numbers 3 and 4. At the end of my time, I'll spend a few minutes talking about those root ligaments. I learned in medical school that the human menisci had very little in the way of blood supply, but indeed they do have a peripheral source of blood, and that actually comes from two particular characteristics. The first of these are branches of the genicular vessels performing or producing a perimeniscal capillary plexus shown by the red squiggly line here labeled number 1. The second, a synovial reflection adherent to the meniscal surface at the top and bottom shown by the number 2 and again located in the periphery. This will lead to an outer zone, somewhat narrow, vascular in nature called the red zone, and a much wider inner zone with little or no vascularity known as the white zone. Meniscal tears in the red zone do well, sometimes even without therapy. Those in the white zone require surgical resection. And one other point, there is no red zone posterolaterally, that is in the lateral meniscus, adjacent to the popliteus tendon. Now, this is a critical slide because collagen is key in understanding, in fact, what goes on with meniscal failure. Taken from the literature is this beautiful diagram. Let me run through it fairly quickly. If we peel away the collagen at the superficial regions of the meniscus, we're left with a highly organized central structure. Within that central structure are two forms of collagen bundles. The first of these, are longitudinal circumferential collagen bundles. They are shown by the yellow arrow. They are located in the outer half of the meniscus. Here's one, for example, and they connect the anterior and posterior portions of that menisci. Here in my drawing, I show you those as these red cylinders in the outer half of the meniscus. The second pattern of collagen are the radial tie collagen bundles that come in from the periphery, shown by that orange arrow, and then we can follow them, shown by the arrowheads, all the way to the inner aspect of the meniscus. I kind of draw them here as this structure, and you can see the radial tie fibers tied together, the peripheral and central aspect. That's what you need to know. Longitudinal circumferential collagen fibers, outer half of the meniscus, tying together the anterior and posterior parts, and the radial tie fibers that tie together the central and peripheral portions. Now, the main reason we get meniscal tears relates to something known as hoop stress. And indeed, it was hoop stress that produced the crack in the Liberty Bell that we have in Philadelphia. To give you an idea what hoop stress is, this is a sagittal section through the posteromedial aspect of the knee. Here is the femoral force being applied at an angle with both horizontal and vertical component. The vertical component is in fact resisted by a vertical component of the tibia, but the horizontal component is not resisted by what's in the tibia, and that relates to hoop stress or produces hoop stress. Hoop stress tends to drive the meniscus from the joint, shown in the bottom right. Resisting that are those longitudinal circumferential collagen fibers located in the periphery of the meniscus. Now we come along and we try to diagnose meniscal tears based on MR using two criteria. Typically, the normal meniscus, shown here and here, is triangular in shape, smooth, with a sharp point of low signal, although there may be some areas of intermediate signal. More about that in a moment. The first criteria of a tear is abnormal meniscal contour, shown here. The second is abnormality of meniscal signal. With regard to abnormality of meniscal signal, we require intermediate or high signal that violates this surface at the bottom, this surface at the top, or the tip of the meniscus, but not the periphery. Of these two criteria, one is terrific and one is not so good. The terrific criterion is the abnormality of meniscal contour. If you can rule out surgery, an abnormality of meniscal contour in any way, truncated, irregular, what have you, in the absence of meniscal surgery, represents a tear. So the first thing I do in looking at MR images of the knee is to study if there is fibrosis, here thickening of the ligamentum mucosum, because indeed sometimes the history that is provided is not accurate. This is the first thing that I do. The second criterion is not so good, because you see, sometimes we have intermediate signal within the meniscus that does not reach the surface, hence no tear, and sometimes it reaches the surface. And I've noticed over the years when reading out with residents or with fellows that when trying to decide whether or not that alteration in signal intention reaches the surface, you will note they get closer and closer to the computer screen, trying to turn that last pixel from dark to bright and to call it a tear. These tears, these alterations in signal intensity should be obvious at a distance. And if you're not sure, you should indicate that and suggest re-imaging over a period of time. They should be obvious simply at a distance. So my advice, sit comfortably when you view these MR images. The first of our three basic tears is a longitudinal vertical tear related to compression. This tends to drive the meniscus from the joint, but the root ligaments are intact. The first tear that occurs is a micro tear along the axis of the hoop stress. Look at this. That micro tear encounters resistance by the longitudinal circumferential collagen bundles. It changes direction. It takes the path of least resistance. This is a longitudinal vertical tear. Longitudinal because it's an AP dimension, vertical because it's mainly vertical. The length of this longitudinal vertical tear relates to its antero-posterior dimension. If we look at this, perhaps in the sagittal plane, here is a longitudinal vertical tear, top to bottom, complete. Staying in that plane, we can see, in fact, that it looks exactly the same in a different image. Kind of boring. And by that, I mean not only is there a line top to bottom, but the distance between that line and the periphery of the meniscus remains the same, because these tears propagate parallel to those longitudinal circumferential collagen fibers. So to give you an idea, the first sagittal image here, the second sagittal image here looks the same, the third here looks the same, the fourth here looks the same. You can figure out the length of these longitudinal vertical tears. Some people suggest if they're over 9 or 10 millimeters in length, they are unstable. The second pattern of failure, the basic tear, is a longitudinal horizontal tear. This, known as a cleavage tear, relates to shear. It tends to begin near or at the apex or inner margin of the meniscus and takes the path of least resistance toward the periphery. At the periphery, it may branch because of those longitudinal fibers, collagen fibers. The length of a longitudinal horizontal tear relates to its antero-posterior dimension. The width relates to its central peripheral dimension. It is these cleavage tears or longitudinal horizontal tears that are associated with parameniscal cysts. These occur both medially and laterally. They tend to be larger and travel for a longer distance on the medial side compared to the lateral side. Many, but not all of them, communicate with the joint. Sometimes they communicate only with extensive mucinous change within the meniscus. The third basic type of tear is a tricky one. It is a radial tear. All right. This is not a longitudinal tear. It does not have an AP dimension. It only has a central peripheral dimension. And as it goes from the tip toward the periphery, it destroys those longitudinal circumferential collagen fibers. Now, what do those fibers do? They tie together, of course, the anterior and posterior portions of the meniscus. So these tears, these radial tears, may in fact open up like a book, creating a gap that you should note and measure on the MR images. Here you can see a radial tear in yellow, much like the radial tie fibers, interrupting these longitudinal circumferential collagen fibers. If you image along the gap, you see the sign of empty or empty meniscus. You don't see a meniscus. Here we do not see the posterior horn of the medial meniscus. Here's the anterior horn because we're imaging the meniscal gap. Now, the displaced radial tears are known as parrot beak tears, and I draw one in here to point out something that is critical. Let's go ahead and image this. Here's the first of our images, and what do we see? We see a vertical line, but not in the periphery, now in the inner half of the meniscus. As we trace this parrot beak tear, take a look at that. That longitudinal line, in this case, is marching toward the tip. This is known as the marching cleft sign. But the important thing is vertical lines in the inner aspect of the meniscus usually indicate radial tears, okay, not longitudinal vertical tears. And here's an example in a patient showing you the marching cleft sign of a radial tear. Now, this is also a critical sign. If you go to the sagittal images and find the posterior cruciate ligament, on your next medial image, you should see a lot of the meniscus. And on your next one, the entire meniscus. Now look at our case. Here is that medial image with the PCL, and on the next image, we don't see very much at all. What you are looking at should not surprise you. You're looking at a radial tear involving the inner portion of the posterior horn of the medial meniscus, producing a gap, as opposed to the normal situation where, in fact, the meniscus dives down as a posterior root ligament. Now, if I had to tell you what I believe is the most important sequence on an MR examination, it's my belief that it is the coronal fluid-sensitive fat-suppressed sequence because it shows you ligaments and contusions. Okay, I believe it's the most important. And if I were to tell you what is the most important image in an MR examination of the knee, it is this image right here, showing you this particular region. And in fact, I will go even one step further. This is the most important 1/2 image. You've got to look at this particular inner aspect of the posterior horn. Radial tears of the meniscus and root ligament problems involving that posterior root produce abnormalities here. Study that particular region. With regard to displaced meniscal tears, I would just indicate to you that a displaced longitudinal vertical tear is a bucket handle tear. A displaced longitudinal horizontal tear is a flap tear. Here you can see it extending down, eroding the tibia. And as we've already talked about, a displaced radial tear is a parrot beak tear. We're going to finish up in the last few minutes by, in fact, talking about the meniscal root ligaments. Now, there are 4 of them, but I'm going to concentrate on the posterior root ligament of the medial meniscus. At the time of arthroscopy, the root ligament problems account for 10% of things that are found related to the meniscus. The posterior root ligament is probably the most common site of abnormality, but when you're dealing with ACL tears, always study the root ligaments of the lateral meniscus. And these attachments are strong. They possess both central and supplementary fibers. So when you lose that attachment, significant things may occur. I wanted to show you a partial tear of the root ligament, beginning at the image on your left, okay? At this particular point, this is not normal, but it could be missed. But there is a little bit of altered marrow signal in the subjacent tibial plateau. This has been designated the prequel of a root ligament problem. Now, it isn't specific, but if you see that, go back and study the root ligament. 4 months later, only a little bit of the posterior root ligament of that medial meniscus is visible. So a high-grade partial tear is seen. This is a complete tear of that root ligament, looking very much like a radial tear of the meniscus, as we just discussed. There is a meniscal gap. And indeed, if you stay on that same coronal plane and you look at it elsewhere, you see a variety of findings that seem to fit together. Because we've lost the attachment of that posterior root ligament, there is meniscal extrusion, leading to bowing of the tibial collateral ligament and other components of the medial collateral ligamentous complex, leading to periligamentous edema, leading to reactive marrow edema, which in this case is in the tibia, but sometimes is within the femoral condyle. And you always want to look for linear components because there's an association with insufficiency fractures. So it's like a great sentence that you can use. Disruption of the posterior root ligament, extrusion of the meniscus, bowing of the ligament, periligamentous edema, reactive marrow edema with or without an insufficiency fracture. Involvement of that posterior root ligament of the medial meniscus has been associated with what originally was called spontaneous osteonecrosis of the knee. This is spontaneous osteonecrosis as originally described. Collapse of bone, fractures adjacent to the subchondral bone plate, and a lot of marrow edema. 2 months earlier in this particular case, a classic tear involving the posterior root ligament of the medial meniscus with peripheral meniscal extrusion. There's another finding that has been associated with problems of the posterior root ligament of the medial meniscus, meniscal ossicle. Now, some people regard ossicles as normal variants, particularly in the posterior horn of the medial meniscus. They are described in large cats like lions and tigers, so they may be normal variants. But whenever you see them, and here's a classic example of what they look like, you should study the posterior root ligament of the medial meniscus, because in some cases they represent avulsion, as shown here, with an ossicle pulled off of the tibia. In other cases, there's a root ligament avulsion without bone, but secondary heterotopic ossification occurs within the torn ligament, simulating a meniscal ossicle. So what I've done in my period of time is, in fact, to look at the meniscus of the knee. And for this part, I've reviewed the structure and function of the meniscus, emphasizing its collagen framework. If you understand the collagen, you can understand the three basic patterns of failure. We've looked at those patterns of failure, and we've also studied particularly the abnormalities that occur within the posterior root ligament of the medial meniscus. It's now my privilege to introduce Christine Chung, my associate here at the University of California, San Diego, and she will talk about the triangular fibrocartilage complex of the wrist. Christine?
Hello, my name is Christine Chung, and I will be discussing the triangular fibrocartilage today. I wanted to thank Dr. Resnick for including me in this course. In our short time together, we will discuss the elegant complexity of the structure of the triangular fibrocartilage complex and how it informs function, MR appearance, and patterns of failure. As imagers, this is how we perceive the triangular fibrocartilage. On this coronal fluid sensitive sequence, the low signal intensity structure here between the proximal carpal row and the ulna with an attachment at the distal radius. If we put on the hat of the orthopedic surgeon, this is how the triangular fibrocartilage may be perceived. The dissection here showing the radius, the triangular fibrocartilage reflected with the ulnar styloid here, surrounded by a mantle of tissue that composes the complex structures of the triangular fibrocartilage disc proper. On this sagittal specimen photograph, we see something similar with the triangular fibrocartilage blending to adjacent tissues. These diagrams show the complexity again of the triangular fibrocartilage and all of the supporting tissues, really subtle transitions that occur between these structures that are perceived by the radiologist, by the orthopedic surgeon. As we then try to understand the function of the triangular fibrocartilage, we're now perceiving this region of the body, perhaps through the eyes of the physical therapist or even the orthopedic surgeon. As you think about the triangular fibrocartilage and its components and the motion of the wrist, pronation and supination, the changes with regard to the motion and position of the ulna, we can imagine that this is a major stabilizer of the distal radial ulnar joint. As we consider moving our own wrist with radial and ulnar deviation, you can imagine that the triangular fibrocartilage also acts to extend the articular surface of the radius and provide a platform or foundation of the ulnar aspect of that proximal carpal row. And as we consider the various different ways we load the wrist, from the high performance athlete vaulting and using their upper extremities and wrists as weight bearing articulations, to activities of the weekend warrior or simply daily activities, we understand that that triangular fibrocartilage can serve as a shock absorber. As we think about hanging or pulling things with our wrist and the distraction that occurs at the level of the proximal carpal row to radius and ulna, we know that the triangular fibrocartilage complex resists those tensile forces, suspends and tethers the distal radius, the ulna, and the carpus. Well, now I'm going to ask you to look at the triangular fibrocartilage through the eyes of the pathologist to help us understand how structure informs function. And of course, we'll then discuss how those things help us to understand the MR appearance of the triangular fibrocartilage and patterns of failure that we will encounter on MR imaging and clinically. As we consider the triangular fibrocartilage disc proper, look at the H&E preparation, the elastica von Giesen, the polarizing light microscopy from the H&E preparation, and we can see this densely packed interlaced collagen fiber pattern. Now, if you superimpose that on the slab of tissue that as an imager you perceive the triangular fibrocartilage to be, you can understand that the function, the primary function of the TFC proper, the disc component, is to buffer that axial carpal force. That becomes very important as we think about patterns of failure and function proper. As we look at these two histologic preparations, here the H&E in the polarizing mode, we again get this idea that the primary component of the fibrocartilaginous disc is comprised of this densely packed tissue. And as we look at the transition moving to the ulnar aspect, we can identify the fact that that tissue becomes more organized, or perhaps a better way to put that is organized in a different fashion. So here the disc with those densely packed connective tissues moving to the transition where we then see the attachments to the ulnar styloid. You can see clearly that the morphologic change here and the histologic change go hand in hand, as well as the function. The disc being the shock absorber as you load the proximal carpal row to the ulna, then the tensile forces really being resisted by those linear ligamentous components attaching that disc to the ulnar styloid. Well, if we look even closer at the histology of the ligamentous structures, including the radio-ulnar ligaments, we see a very different appearance to the H&E, the elastica and H&E polarizing components, reflecting the structural change. Still densely packed, but now we see that those collagen bundle fibers are very parallel in appearance. And as we consider the imaging appearance, that really makes sense, because here we see what we know to be the MR appearance of a ligamentous structure, linear, low in signal intensity, and we know that this resists the tensile forces as you consider supination, pronation, the rotation of that ulna back and forth at the level of the distal radioulnar joint. Well, let's move now to the histologic appearance of another component of the triangular fibrocartilage complex, that of the ulnomeniscal homologue, shown by number 7 in the diagram. As you look at the histologic preparation, I think it gives you a really vivid idea, a picture in your mind of how different this tissue is. Rather than that densely packed collagen, now we see that it's very loose in configuration with spaces that exist between those collagen fibers. And now the function really makes sense to us. This is a buffer or a cushion as you consider that tissue that extends along distally, the ulnar aspect of the wrist. Now, as you look at this coronal fluid sensitive sequence, here you're seeing the triangular fibrocartilage, and as you move distally, you see the ulnomeniscal homologue, the cushion that exists. In this case, all of these spaces between the collagen fibers have the opportunity to have inflammatory change, high signal intensity here, synovial hypertrophy interdigitating between those collagen fibers. And so the histology, I think, really helps us to understand the findings that we see, the morphology, as well as the findings that we see in the setting of pathology. So again, the structure, the histologic structure really helps us to understand the MR appearance, both the morphology and the signal intensity, the densely packed tissue reflecting the triangular fibrocartilage proper, the tight parallel organization representing the appearance of ligamentous structures. And because these tissues are so tightly organized, they hold on very tightly to those hydrogen molecules, making them short T2 tissues. Excuse me. That means that by the time we excite the protons, we switch from the transmit to the receive mode on our MR scanners, that excitation of the proton has already relaxed so that these short T2 tissues are dark or anechoic on all imaging sequences. The important thing to note there is that by the time we see high signal intensity in these structures, there's very significant structural alteration, and they have moved from short T2 to long T2 tissues. So we're seeing the manifestation of disease on MR at a very severe or end stage type of injury. Don very elegantly talked about the ways that we identify failure in musculoskeletal tissues in the last lecture. And so clearly in every musculoskeletal tissue, we're going to look at morphology and signal intensity. As we consider structural failure in the ligamentous structures, as well as the triangular fibrocartilage, we're going to look for areas of tears or discontinuity. In the axial proton density and proton density fat suppressed sequence here, we see the discontinuity of the ligamentous structure. This is a more subacute presentation without a lot of high signal intensity in the soft tissues. Here, the triangular fibrocartilage discontinuous from the radial attachment. Here, not enough tissue in the region of the triangular fibrocartilage with displaced disc into the distal radioulnar joint. We're also going to look for secondary findings of failure, which may be change in alignment, subluxation of the ulna, or if we put contrast into the radioulnar articulation, we may see that that compartment is no longer sealed tight and fluid extends into the distal radioulnar joint. All secondary findings of failure of those tissues. The triangular fibrocartilage injury classification is well known and includes the Palmer type 1 with traumatic injury as well as a degenerative classification system. As we think about the type 1 traumatic lesions, let's look at them on MR. Here you can see a non-fat suppressed and fat suppressed image, coronal imaging plane. We see high signal intensity, linear in nature, that traverses the triangular fibrocartilage from the carpal side to the ulnar side of the articulation. As you characterize this linear high signal intensity, there is not fluid signal intensity which traverses it. So you know that this is torn based on the signal intensity characteristic, but the further characterization of whether or not that's a communicating perforation is difficult to make without putting contrast into the articulation. That's shown here with both MR arthrography on the left and CT arthrography on the right. As we've placed contrast material into the radiocarpal articulation, we see that that contrast traverses the area of discontinuity on both of these two cases, and that helps us to further characterize this lesion for our referring physician. The Palmer type 1B is ulnar-sided failure. I'm showing you two types of examples here. In the skeletally mature patient, we can see that the triangular fibrocartilage disc is no longer attached to the ulnar styloid or fovea, those lamina completely discontinuous. Contrast was placed into the radiocarpal articulation, and we see it extending into the distal radioulnar joint through the area of failure of those lamina or ligamentous structures. In the case of the skeletally immature patient here, we see that the ulnar styloid base fracture serves as the ulnar-sided failure. A reminder here in the normal appearance with the triangular fibrocartilage firmly tethered to the styloid and fovea of the ulna. As we look at this type of failure of the triangular fibrocartilage, in this case, we're seeing both failure at the ulnar-sided lamina or ligamentous attachment to the ulnar styloid, but also failure here at the junction of the triangular fibrocartilage to the extrinsic ligaments that stabilize both the palmar and dorsal aspect of the triangular fibrocartilage. And finally, for the last type of failure of the TFC in the traumatic classification, an avulsion from the radius. As you look at this coronal image, you see the articular cartilage, which undercuts that TFC attachment. No fibrocartilaginous tissue left at the radial attachment and the gap or space that exists here with fluid traversing it and extending into the distal radial articulation. A proposed modification in the contemporary MR literature suggests that we should be looking closely at the TFC attachments to those extrinsic ligaments of the wrist. And as we remember that those extrinsic ligaments, in addition to the ulnomeniscal homologue, are loose connective tissue, then when we start to assess them here, a coronal image to the wrist at the dorsal margin, we see that they're not such discrete linear low signal intensity structures, but they reflect the histologic structure in that we can see high signal intensity synovial hypertrophy, perhaps even fluid, extending into those loosely parallel connective fiber tissues. Looking at the sagittal image, we can perceive the discontinuity here of the TFC to the dorsal extrinsic ligament, as well as the abnormal attachment to the dorsal carpal bones. On the bottom, the ulnomeniscal homologue, again shown with high signal intensity. Don't forget to characterize those extrinsic ligament and loose connective tissue structures. The Palomar classification for degenerative change does exactly that. It looks at findings of degeneration in this coronal fluid sensitive sequence, all the harbingers of osteoarthrosis and degenerative change in the wrist, including cyst formation, reactive Merritt change, full thickness chondral loss, as well as triangular fibrocartilage pathology. As we think about our assessment of the wrist through MR imaging, I think that we have to move beyond the structure. We have to think about what brought the patients to us and remember that from the imaging standpoint, we don't always image pain very well. So think about your imaging studies and try to identify the potential pain generators. Clearly, as we look at images like this, we're thinking about altered marrow signal intensity. We're thinking about synovitis as things that could result in pain for our patient population. So take a close look at the capsular structures. Try to identify whether or not there's thickening and high signal intensity to suggest synovitis. Again, that may be the pain generator in that patient. As we consider mechanical possibilities or reports that lead to imaging from our referring physicians, clicking, locking, giving way. On MR, we don't have very robust ways that are part of our everyday clinical workflow to evaluate these mechanics, but they are certainly within our near future. As we consider tools like 4D MSK MRI, where through pronation and supination, we can look inside the articulation to see how structural changes may occur. Similarly, through radial and ulnar deviation, we can identify things from the standpoint of the mechanics that our referring physicians may be trying to evaluate. So in our time together, I hope that I have convinced you that structure informs function. The MR appearance, the patterns of failure in the triangular fibrocartilage complex, that we should look beyond simply the imaging and try to identify pain generators in the patient population for our referring physician base. Non-invasive functional MRI assessment of joints is in our future and not so distant future. So with that, I would like to thank you for your attention. Once again, thank Dr. Resnick for the invitation to speak with you all and introduce David Rubin, a colleague and friend. This low resolution image for plausible deniability for Dr. Rubin, but clearly he has a lot of experience with overhead motion and repetitive microtrauma. Thank you so much.
Thanks, Christine, and thanks, Don, for putting together this course and asking me to speak about the labrum. Here's my disclosure. You've already heard about the meniscus and the disc. The labrum is a fibrocartilage associated with ball and socket joints. You probably recall that these allow tilting and rotation, but not translation. The labrum is a fibrocartilage that rings around the peripheral edge of the socket part of the joint. The meniscus and disc sit between bones, which is different than the labrum, which sits really on the outside of the bones. It's attached to the socket and goes on the outside of the ball. This is important because the ball The femoral head or humeral head is what does the damage to the labrum by pressing against the articular surface, so all tears are going to start on the articular surface. This is different than the disc or meniscus, where tears can occur on either side. If we look at the two main ball and socket joints in the body, they are the hip and the shoulder. In the hip, we have the acetabulum, which is a horseshoe-shaped, fairly deep bony socket, compared to the glenoid, which is reniform and relatively shallow, and that reflects their different functions. The acetabulum is designed for stability, the glenoid for mobility, allowing the arm to move freely. If we now add on the articular cartilage and labrum, as seen in this drawing provided by one of my colleagues, Mike Stadnick, we can see that the articular cartilage is here on the inside and the labrum goes around the outside. On the shoulder, it goes completely around the periphery of the socket. On the acetabulum, a transverse ligament inferiorly joins the lower parts of the labrum together. The labrum is also an important attachment point of several main structures. For example, here in the shoulder, the long head biceps tendon. The labrum has several functions. The first is to increase stability, and this is more important in the shoulder compared to the hip. It does this by increasing the depth of the socket and the volume of the joint, and also by acting as a mechanical bumper, preventing the humeral head from translating. The common analogy people use is a golf ball on a tee, and as you know, if a wind comes along, that golf ball can easily fall off that small tee, the tee being the glenoid. So we're going to take our glenoid now and make it deeper by adding the labrum around the periphery, and you can see how that increases the depth of the socket. Not only that, but we're going to push the humeral head into the glenoid. So if I put my foot on top of that golf ball and press down, now it's going to be very hard for the wind or even your golf club to knock it off. In the shoulder, what's going on is the rotator cuff is not pushing, but actually pulling the humeral head into that socket to make it more stable. The second major function is chondral protection, and this is more important in the hip compared to the shoulder. The labrum produces a vacuum seal and a closed space between the articular surfaces where a small amount of pressurized fluid can exist, and this decreases the contact of the two articular cartilages against each other and greatly decreases the contact stress. So if we look at another analogy now, the labrum is like a suction cup, and a suction cup works by being very stiff on the inside, and in the socket, that's where we have our articular cartilage and bone, which is relatively stiff, and sort of floppy or flexible on the outside where the labrum is. So what happens is these tips of the labrum are mobile, and when they contact the femoral head, they make a small closed space, and in that space we have a small amount of fluid, and that fluid prevents the femoral head and acetabular socket from directly contacting against each other. You can see the normal mobility of the labrum in an example like this. This is a normal shoulder, same patient imaged in 3 different positions. And you notice that in internal rotation, the labrum is sort of shaped like a comma. In neutral position, round, and in external rotation, triangular. In external rotation, because we're pulling on it by pulling on this anterior band of the inferior glenohumeral ligament. The third major function of the labrum is to act as an attachment point for ligaments and tendons, and this is more important in the shoulder than the hip. And we're all familiar with these different structures. So for example, here in the anteroinferior shoulder, we know that's not a labral tear. Instead, that's another structure attached to the labrum. And we could look on several sequential slices and see that's the anterior band inferior glenohumeral ligament running from the glenoid to the humerus. Similarly, in the posterior-inferior hip, that's not a labral tear. That's a normal structure. And on the next slice, we can see that's the transverse ligament. Labral disorders include variants, which act as pitfalls, and this is more important in the shoulder compared to the hip, and then labral tears. And in all cases, it's the ball, the humeral head or femoral head, that's the culprit that's doing the damage to the labrum. In the hip, the underlying problem is often abnormal shape of the bones, and in the shoulder, it's often abnormal motion. The key observation to make these diagnoses is location. So to describe location, I'm going to use the clock analogy. So in the shoulder, we make the biceps tendon the 12 o'clock position, And the same has been done in the acetabulum, where we take the center of the transverse ligament and make that the 6 o'clock position. And for today, I'm going to say all the low numbers from 1 to 5 o'clock are anterior, and all the high numbers, 7 to 11 o'clock, are posterior, regardless of whether we're talking about the right or the left side. Starting with the shoulder now, the variants are mostly located superiorly and anterosuperiorly, whereas the lesions can be superior, antero-inferior, or posterior. Labral tears can be associated with labral cysts, and importantly can be associated with bone loss, though we won't have time to talk about that today. The main variants are located superiorly or anterosuperiorly, so from the 12 to 2 o'clock position. The most common is a sublabral recess. This is located under the biceps and under the labrum. So if you look at a recess on coronal MR images from anterior to posterior, this is an MR arthrogram. That structure is the long head biceps tendon. The triangle is the labrum, so this contrast is located under the biceps and under the labrum. When we move slightly posteriorly, we still see the recess. That's okay because we can still see the biceps. But when we move posterior enough that we no longer see the biceps, we don't see any contrast under the labrum either. In the axial plane, that's the humeral head and that's the glenoid. In this patient, the biceps attaches to the labrum where that black arrow is. So this contrast is under the biceps and under the labrum, but there's no contrast posterior to the biceps. The second variant is a sublabral foramen, and this is located anterior to the biceps and is essentially detachment of the anterosuperior labrum. So here in this case, there's the biceps tendon. So that contrast or fluid is now anterior to the biceps between the detached anterosuperior labrum and the underlying glenoid. And on the coronal image, you can see why this is sometimes called a sublabral hole. The third main variant is a Buford complex. This looks like a foramen, but instead of a detached anterosuperior labrum, there is no anterosuperior labrum. It's been replaced by a thick metaglenohumeral ligament. And in all these variants, importantly, once you're below the equator of the glenoid, the antero-inferior labrum is normal. So this is a Buford complex. On the axial plane, superiorly, we have what looks like a foramen, except that's not the anterosuperior labrum. We go to the next slice and we see the anterosuperior labrum is absent. That structure is different. We follow it and it parallels and eventually fuses with the subscapularis, so that's the middle glenohumeral ligament. The antero-inferior labrum is intact, so from top to bottom, that characterizes a Buford complex. Slap lesions are tears of the labrum, the superior labrum torn anterior and posteriorly with respect to the biceps. The etiology is a little controversial, whether it's due to abnormal motion and twisting of the biceps tendon or abnormal humeral head translation. When certain throwing athletes have their arm in the cock position, it's not clear. But these occur at the 12 o'clock position and then go a variable distance anteriorly and posteriorly. In the radiologic and orthopedic literature, there's many subtypes that have been described, but what's most important when you make this diagnosis is number one, the tear is within, not under the labrum, and number two, the tear extends posterior to the biceps. Recall that all those numeral variants are located either at or anterior to the biceps, never posterior. So I'm just showing you a slap tear here on a CT arthrogram because I think it's a little bit easier to understand. So that gray material on top of the bone is the articular cartilage. Now on an MR examination, that would be relatively bright, and you wouldn't want to mistake that for a labral tear because it's under the labrum. On the other hand, this contrast is inside the labrum, and we see it on an image that's both anterior and posterior to the biceps, and that's the definition of a slap lesion. Here on a T2 weighted MR examination, it's the same thing. That is inside the labrum. We can see a little bit of normal labrum underneath it, and we see it both anterior and posterior to the biceps, making this a slap tear. We're very confident in this case that's a true tear because we have an associated labral cyst. Here's what that looks like in the arthroscope. There's your glenoid, your superior labrum, and long head biceps. The probe is inside the tear that's within the labrum, and the repair is basically to reattach that torn labrum to the underlying glenoid. Now, I said that there are several different subtypes, and you can try to determine which you're looking at on your images, but what your surgeons really want to know is yes or no, is the biceps anchor involved, because that's what's going to determine treatment. So in a case like this, it's very easy to say, yes, that tear clearly involves the biceps anchor, and the treatment of these is now no longer repairing them, but what we see here. So there's your humeral head and biceps, and this is a knife that's cutting through the biceps, and the treatment is simply cutting the biceps, doing a tenotomy with or without a tenodesis. Tears of the anteroinferior labrum or Bankart lesions are associated with instability. So we see detachment of the labrum here from the underlying bone and here from the periosteum as well. These are located from the 4 to sort of 530 position on the glenoid. Now we're used to looking at those on the axial images, but frankly the other 2 or even other 3 imaging planes are just as important, especially if the tear is not displaced. So on the coronal and oblique sagittal images, you can always find this structure. That's the anterior band inferior glenohumeral ligament, and follow it back to the labrum. Once you find the labrum, you can now determine, is that attached or detached from the bone, and is it where it belongs? In this case, it's detached and displaced slightly inferiorly. In the A-bear images, we put the patient's palm on the back of their neck, so the humerus is sticking upwards, and because we're now putting tension on that anterior band of the inferior glenohumeral ligament, it tends to pull the labrum further away from the glenoid, making it easier to see. Here's what that looks like in the arthroscope. There's your glenoid and humeral head. There's the labrum, and that cleft is going to be the tear at the base of the labrum, and here it is being repaired down to the underlying bone. Traumatic tears can occur just about anywhere. Posterior is common in a patient like this who's a football player, a blocking injury where his arm was pushed backward, and you can see it has the same characteristics as those anterior tears, detachment of the labrum, this time the posterior labrum, from the underlying bone. Here it is centered at the 9 o'clock position. And tears that occur anywhere can be associated with labral cysts. Very commonly it's in this location, that's posterior-superiorly. You can see these labral cysts will fill with fluid on your T2 weighted images, but don't necessarily have to freely communicate with the joint and contain contrast if you're doing an MR arthrogram. The problem with these cysts is that they can grow and go into different locations. This one has traveled into the spinoglenoid notch, where it's pressing on this structure, the suprascapular nerve, and producing subacute denervation of the infraspinatus muscle, which is increased in signal intensity compared to the supraspinatus and teres minor muscles. For the hip, there are variants, and then there are lesions. The tears tend to be associated with bone disease like femoroacetabular impingement or developmental dysplasia, but can also occur with normal bones, and these are usually traumatic tears. They can also be associated with cysts. The main variant to be concerned with is this labral sulcus or recess, and this is controversial. If you look at the literature that looks at prospectively MR arthrograms or cadaver studies, recesses are not reported. The only reports come from studies that look at arthroscopies, and really from only a few different centers. So for example, this place in Zurich found that in their arthroscopies, about 18% of patients had a sulcus anteroinferiorly. When they went back and looked at those MRs, they said, aha, we can see those, but really what they're looking at, everyone else would have just called a tear. Similarly, from Walter Reed, they found most recesses in the arthroscope located posterior-inferiorly. All those were visible retrospectively on MR examinations. And the same from Australia, 2 different locations, anterosuperior and posterior-inferior. So these have really been reported everywhere in the periphery of the acetabulum, but really at only a few locations. And here are images from those 3 studies, and the arrows and arrowheads are pointing to what was called recesses. When I showed these to the surgeons I work with, they said, well, those look like labral tears, and we would have repaired those. So the key here is ask your surgeon. If they're one of the few that believes there's such a thing as a labral sulcus, then you may need to be careful when you describe what looks like a tear when there are no secondary findings. In all other cases where your surgeons don't believe in this, it's very simple. Everything you see that's abnormal, you can call a tear. These tears occur, as I said, with different bone abnormalities. I think everyone's familiar with femoroacetabular impingement, the cam deformity where we have asphericity of the femoral head, here due to an extra amount of bone anterosuperiorly. Very hard to see on the AP examination, but this extra bone is now going to press into the anterosuperior labrum, and that's where we're going to get these labral tears that start on the articular surface, sort of at the 1 to 230 position. Bone abnormalities can also occur on the acetabular side, for example, where we have extra bone, coxa profunda, where the superior acetabulum is retroverted, or we have a prominent anteroinferior iliac spine. Now, in all these cases, even though the abnormality is on the acetabular side, it's the femoral head that's pressing the labrum into that abnormal bone and creating the labral tears. In developmental dysplasia, we have decreased acetabular coverage, either laterally, like we see here on the coronal image, or anteriorly on the false profile position. And in these cases, it's the femoral head that's pushing upward against the labrum where there's no acetabular backing and creating a tear that tends to be a little bit more superior than we see in femoral acetabular impingement. Tears can also be traumatic. This one is posterior in a professional baseball pitcher and is associated with a chondral defect located at the posterior quadrant. And this one is located posterosuperiorly and also associated with a cyst occurring posterosuperiorly. And here's what that looks like in the arthroscope. There's your femoral head, the torn labrum. The probe is now moving the labral tear out of the way, and we can see the opening to that labral cyst. And the treatment of these is often just to repair the labrum down to the acetabular socket, and the cyst will go away on. A few caveats. Labral tears are very common in asymptomatic individuals, so just because you've seen a labral tear doesn't mean that's what's causing the patient's symptoms. Very, very common in the elderly. For example, in cadavers, more than 90% of specimens will have a hip or shoulder labral tear. The acetabular cartilage is probably more important than the labrum, so you want to look carefully at the acetabular cartilage because abnormalities of that structure will affect what surgery the patient can have. And then finally, the bone is even more important. Interestingly, different treatment in the shoulder, we tend to add on bone, for example, in a Latarjet procedure, and in the hip, we tend to remove bone, for example, in a patient with FAI. So the take-home points for the labrum, the primary function in the shoulder is to increase stability. In the hip is chondral protection. The common injuries in the shoulder due to instability are anteroinferiorly and slap tears superiorly, and in the hip due to FAI or DDH at the superior and anterosuperior part of the labrum. I'm going to stop there. Thank everyone for listening in remotely and ask everyone to please remain safe. Thank you.